it's very clear that the safest scenario is you are with your nuclear family that you live with and have routine contact with, nobody else comes over, and that's it. That's your Thanksgiving, your holidays, your Halloween, etc.
That's a lot of leftovers, because
it's a lot of leftovers if you cook like my family cooks.
Yeah, for 4 people.
Right. So, so I think you take into account some of these risk mitigation strategies. Do you have a lot of people coming from out of town that are going to be using travel like airlines, or mingling with a lot of additional people outside of your bubble? That is a potential risk. Are you having dinner outside? That could be potentially more effective because of the increased ventilation. Are you able to socially distance? Again, maybe more effective. So it's about risk mitigation strategies. I think it's very clear what the safest scenario is, but unfortunately that's not feasible for many people. The United States has invested a lot of money into several potential vaccine candidates, and a lot of this of the vaccine part has been politicized, and that we all know, and I'm going to kind of stay away from that as much as I possibly can. But politicized or not, everybody wants a vaccine as fast as possible. And so phase 3 trials means that they are recruiting large numbers of people, on the order of tens of thousands of hopefully diverse kind of representatives of the United States population, to test these vaccines in. Many of the vaccine candidates may include 1 or 2 doses, so there's several that include 2 doses, and measured several weeks apart. And so it doesn't mean that an answer is around the corner. After dosing in the beginning of a clinical trial, there will of course be a period of time where we have to wait to see follow-up and wait to see who is getting sick or who is getting severe illness or things like that. And so all of that unfortunately takes a lot of time. Wrapped up into all of that is, are there any safety signals, or are these vaccines risky? And I think in order to sort of fully stand behind a vaccine and give it to a large number of the population, there are certain things that needs, that vaccine needs to go through. And so the United States is trying to speed up, particularly production. So on day 0, when we all feel like this is safe and effective, they want to have enough doses to start actually giving them to the population, and not, on day 0 say, okay, now we start making vaccines. So that's one of the ways that the United States is trying to speed up being able to actually give the vaccine to a large number of people. But with all of that, it probably will be into 2021 prior to there being a safe and effective vaccine that kind of the FDA can stand behind and start giving. A vaccine could do a number of things. So do we want to prevent hospitalizations? Do we want to prevent infections at all? Or do we want to prevent other complications related to the vaccine? I think all of those vary slightly from vaccine to vaccine. What they're using is sort of their clinical trial endpoints, but have implications for who we would give them out to and what that means. If a vaccine means that you're not infectable, for example, like the measles vaccine, that means that you're sort of safe. But if it means it prevents severe illness, that doesn't mean you're safe. That means that maybe you would have mild disease and could still be potentially a spreader. To my knowledge, most of them are looking at sort of severe medically attended, so moderate to severe illness that requires hospital admission or other medical care. That's the aim that they want to prevent. That doesn't mean that it won't prevent other things like secondary outcomes. For example, are these people not infectable? But that's kind of the thing they're shooting for and the thing that they want to measure biggest difference of, but defined slightly differently depending on the vaccine. Not necessarily, no.
Okay.
And I think, again, this is a tool that we have, just like masks are a tool, just like COVID-19 related therapies are a tool that we can all use to kind of diminish the spread. We also hope that over time, the goal of vaccination will change and our vaccines will get better over time. Again, this is going at breakneck pace. There are hundreds of vaccine candidates that are, in the works in some kind of phase 1 to 3 trials. And so the vaccine landscape may look very different and may look, frankly, better over time. And so our first round of vaccines may be either modest in effectiveness or modest in duration, how long they last, how long do they protect the person who's vaccinated. But we hope that over time, this iterative process will turn into something that's effective and safe. But this has been a huge debate since COVID-19 started. Is it droplet or is it aerosol or airborne? And the crux of that is, what is the size of particle that the virus can travel along? So when we say droplet, we mean 5 micrometer size droplets that come out of your mouth or come out of your nose. And because they're big, well, relatively speaking, they drop kind of within 6 feet of the person.
Okay.
And aerosol is smaller. So do those droplets even get smaller over time and kind of float further in a room or in a space? The prototypical airborne, so this is all a spectrum, but the prototypical airborne virus is measles virus, which is extreme. It's extremely contagious. And luckily we have immunity to measles in our population for the most part, but extremely contagious to the extent that if there is a measles outbreak and someone sat in a room, then anybody that's come into that room in the next 2 hours is potentially needs to be investigated for potential infection.
Which would indicate it's floating around.
Exactly,
Okay.
yeah. So that's kind of the extreme version. So to the best of my knowledge, because this has been a debate since the pandemic started, we are looking at a spectrum where probably COVID-19 mostly spreads via droplets. However, there are specific scenarios, and several have been published and that I can talk about, where it seems that the virus has spread in further than 6 feet distance. And typically that occurs in closed-in spaces that are not well ventilated, or among people that are close together, shouting, screaming, singing, that kind of thing. And so there's been several now published outbreak scenarios where that is sort of hinting at potentially a more aerosol spread of the virus. We all want to know what proportion of this virus is, handshake-borne, what proportion is droplet-borne, what proportion is aerosol-borne. I don't think we have those precise estimates yet. So the WHO has updated their guidance to indicate on their kind of how is SARS-CoV-2 spread page, to say that in some scenarios, probably this is aerosol spreading. As many people know, and many people are also confused by, including myself, the CDC briefly updated their page to kind of state that that may be true in some scenarios, and then it disappeared from their webpage. And to be honest, I don't know the full story about that. The explanation that I've heard was that it was a draft form of guidance that was not posted because there was more of that guidance forthcoming. I don't know the full story of that one. But I will say that supported by the WHO, and we have some specific scenarios in the literature that do indicate that this may be more than just droplet spread. Herd immunity is the thing that we all wish we had. So a good example of herd immunity, I always come back to measles, is measles. Enough of the people in our population have measles that even though this is an extremely contagious virus, if one person has measles in a room, there's enough people vaccinated that this is not going to spread into an outbreak. That has some caveats, certain pockets of the United States, for example, where it does spread into outbreaks because of lack of vaccination. So herd immunity is this idea that enough people are protected against getting a virus, in this case, that it can't continue to spread from person to person to person into a community. That can be achieved through 2 ways. So typically, natural infection can create immunity in an individual person, or vaccination can stimulate immunity in an individual person. We do not think at the current state of the United States, state of infection, even in New York City, where the virus hit extremely hard, that we have anywhere near close to the number of people that need to be immune in order to stop the spread of infection. And with the caveat that stop the spread of infection without additional measures, which is, I think, what everybody really wants, is to be mask-free and not distance, et cetera. In our population, less than 10% of the population, probably less than 5% of the population has actually had COVID-19. And so that's, even if this immunity is robust and long-lasting, that is not enough people to prevent the spread of infection. Well, unfortunately, this answer is simple, which is we don't know. I think that it's a fantastic question, and it's something that we're going to have to deal with as a country on a very large scale very soon. So we know that a substantial proportion of people have post-viral symptoms. So, you feel crummy, you have a virus, you have fevers, you have cough. It gets better for most people, but there's a substantial proportion of the population that go on to have continued shortness of breath, continued coughing, continued fatigue, et cetera, over weeks to months. And that is something that we see with other viral syndromes occasionally. The one that comes to mind the most is mono. But we've seen it in a lot of people, including colleagues of mine who have been unable to work because of fatigue. It seems to affect everyone differently. There's the majority of people, recover and don't seem to have any ill effects symptomatically over time. What we don't know is, does that have future health implications, 50 years down the road for people who get sick? And I think that's something that we are still struggling with and still trying to find out. I think it depends on the person. Certainly people who have substantial comorbidities, pre-existing lung disease and stuff like that, it may be beneficial to see your doctor to sort of discuss what are the potential implications of COVID-19. I think the main problem is that many doctors, including me, wish we had more information. So I have seen a number of patients in my clinic who are, post-COVID with some post-COVID symptoms, and it's hard to know what I can do to help them. So again, I always start off with the safest scenario, which is generally the same thing, which is stay in your house, don't go out of your house, don't see other people, etc. That is safe 100%. However, that's difficult for a lot of people. So again, coming back to those three things, what can I do to mitigate my risk? There is one spectrum of risk, which is indoor Halloween parties with people laughing and yelling and eating and things like that.
Bobbing for apples is out this year.
Bobbing for apples is probably out this year.
I don't know if that was ever in or if that's just a cliche. But
I'm very bad at bobbing for apples, so I'm okay with that. But when you consider trick-or-treating, it does eliminate some of those things. It's typically done outside. Now, that's not true for any listeners that may live in apartment buildings or cities where that is much more common. But trick-or-treating done outside and trick-or-treating often in masks can eliminate some of those things. So the thing it doesn't eliminate is the number of people you're actually seeing.
Right.
So can you take that extra step to sort of eliminate the person-to-person factor potentially and still try and come up with a scenario that's fun for everyone? I will say that Halloween masks don't constitute virus-safe masks. So, so I would say continuing to use your COVID-19 specific mask, plus or minus Halloween masks, if that's part of your costume, I think is something I would say that's definitely needed if that's going to be part of your Halloween plan. I'm trying to take it a month at a time. I remember in March when people said the peak would be in July, I was like, are you serious? Months more? And yet here we are past July. So I say, I'm preparing myself for that, but I'm kind of looking to the short term a little bit at a time.
Yeah.
I think it's really unclear how long this is going to last, but I think it will definitely be shortened by some of these strategies uptaken on a large level by the population.